would you be willing to tell us a little bit about targeted therapies versus, um, uh, I'm reluctant to use the word standard cancer care because of course that's morphing and growing and this is becoming standard of care excitedly.
Right.
But what would you, how would you define targeted therapies or the types of treatments that we can now access because we have this genomic data? Why is that so important?
So I think that along with having the genomic data over the last few years, treatments have been developed, drugs have been developed that specifically target abnormalities in the tumor. And they've been developed in such a way that they're like smart bombs. They target the abnormality in the tumor, and they don't cause a lot of damage to normal tissue. Now, I want to say that I still believe in chemotherapy, and chemotherapy has an important place as well in treating cancer. But what we can do now is we can analyze and pick which patients are the most likely to respond. The reason that chemotherapy historically got a bad rap was not because it didn't work, but maybe it worked in 20% of patients. And then the other patients would have the toxicities. And we couldn't do any better because we didn't have any tools
No.
to be able to differentiate which patients might respond to chemotherapy or might not respond to
Mhm.
chemotherapy.
Mhm.
So these genomic tools now give us, it's not perfect yet, but we're really on the road and we can really see the difference. And this is even more true for targeted therapy where the drugs have been specifically developed, as I said, like smart bombs, to target the abnormality and leave the normal tissue alone. And that has the potential to minimize side effects. But it also means you have to pick the right patient, because if you give a targeted therapy to a patient that doesn't have the target, that's going to be almost completely useless. And that's actually, I also want to mention, that's also very important for immunotherapy.
Yes.
So we're all very excited for immunotherapy, and for a subset of patients, they have phenomenal responses. I've seen patients that were on their way to hospice, and now they're 5 years out and disease-free. In fact, I'm almost hesitant to say as an oncologist that they're cured, but I actually think they're cured. But the important point here is to have, again, the tools, which are genomic tools,
Right.
that pick which patients are the most likely to respond to immunotherapy and which patients are the most likely not to respond or even have side effects or
Yeah.
problems with immunotherapy.
Yes.
So the whole idea here, and it's actually a simple idea, but instituting it is very complex. The idea is that we pick the right drugs for the right patient, that
Yes.
we don't just randomly give patients drugs, that we understand what is wrong in an individual tumor. We put that data through the CureMatch system, and we figure out which drugs are best for that patient. And a lot of times it's not just single drugs, but it's a combination of drugs, because cancer is tricky. It might have many different ways to grow. So we want to hit it in as many ways as possible
Yes.
uh, in order to get the best results.